what is irritable bowel syndrome? As the name suggests, if your bowels or intestines are irritable, and it's syndrome, so it's not a disease. And it's a very common thing we encounter in our clinical practice. Basically, it's a functional bowel disorder, but it's a bowel that is abnormal functionally. That means there is no definite pathophysiology or disease in intestine, but our patients are not functional, and we label them as a functional patients or fictional patients in this kind of a syndrome. So generally patients present with abdominal pain. So it's a functional bowel disorder in which abdominal pain is associated with defecation or change in bowel habit. Either patient present with abdominal pain with constipation or diarrhea. There are various subtypes of IBS that we'll discuss in later slides. Whether it is IBS is associated with constipation or IBS associated with diarrhea. And I'm not just talking about OPD patients, the patient which come to you. 20% of general population fulfill the criteria of IBS. That's why particularly these patients are very unsatisfied patients, and roaming to clinic will with similar complaint that my abdomen is bloated, I am having abdominal pain. There are all the reports are coming to be normal, but I am having the problem and nobody is able to diagnose this. So these are the typical patient, and 2 out of 10 patients in the population suffers from IBS, and it is the most common cause of GI referral. Young females are most commonly affected than men. There are coexisting conditions with IBS. Generally, it is non-ulcer dyspepsia. So again, patient will complain that I am having burning, but or the endoscopies are coming to be normal. Chronic fatigue syndrome. This is a very bad symptoms to have. Patient will be chronically fatigued, bloated, severe abdominal pain, dysmenorrhea, fibromyalgia. Fibromyalgia means diffuse muscle pain, and you will not able to find any cause. Everything will be every investigation, CT scan, laparoscopy, scopies, endoscopies, everything is going to be normal. There are certain behavior and psychological factors associated with it, but let me more than 50% patient has no psychological disorder associated with it. There may be psychological factor, but it is seen in almost less than 50% of the patient. These are depression, anxiety, somatization, or neurosis are very common with this disorder. So thing is that whenever there is psychological stress or any psychiatric disease or even simple lifestyle changes, little bit of stress, unfortunately that is very common with females, secretes the same hormones, same acetylcholine, same serotonin, which controls your intestine movement. So GI intestinal motility is affected, and due to this motility problem, patients are having various symptoms. Second, you will see these patients are very anxious, and they will be visiting doctors with very smaller complaint, a typical type A personality, as we say. Patient will be agitated, patient will be anxious, patient nature will be angry nature. So all this causes a hormonal imbalance in the body, and which can cause the symptoms of irritable bowel syndrome. Basically, it has a definite pathophysiology. IBS is a serotonergic disorder. Increased serotonin is particularly observed in irritable bowel syndrome associated with diarrhea. And this same serotonin is decreased in irritable bowel syndrome associated with constipation. So it is a hormonal imbalance which causes these symptoms. That is why 5-HT3 receptor antagonists are effective in IBS-D, that is IBS diarrhea, while 5-HT4 agonists improve bowel function in irritable bowel syndrome associated with constipation. So we have to see this irritable bowel syndrome as a separate various subtypes. Either it is irritable bowel syndrome with diarrhea, irritable bowel syndrome with constipation, irritable bowel syndrome with predominant abdominal pain, or irritable bowel syndrome with both constipation and diarrhea. So IBS actually represents a state of very low grade inflammation. That's why it's not picked up in any imaging studies or endoscopies. It causes immune activation, which is not detected by test. If we do biopsy, sometimes, rarely, we may find increased number of mucosal mast cells. So again, this is the same kind of a pathophysiology which we see in allergic disorder, common cold, etc. So and these mast cells sensitize enteric neurons by releasing histamine and tryptase. So basically, again, it's an intestinal hormonal imbalance. That is why some patients respond to ketotifen also, which is actually a mast cell stabilizer. Immune activation may be associated with altered CNS processing of visceral pain signals. That is why this patient develop sometimes present with intense abdominal pain without any obvious cause. So, particularly female patient, and that is why we sometimes label female patient is they are faking symptoms, or what we call is they have a depression, anxiety, or malingering or psychotic patient, but actually they are suffering from this functional bowel disorder. Sometimes it is triggered by Salmonella or Campylobacter, but there is no specific correlation seen. There are also associated with intestinal luminal factor. So whenever there is an alteration in intestinal microbiome or normal bacteria present in intestine, it can present as a symptoms of irritable bowel syndrome. That is why specific antibiotic, which we rifaximin, which is specifically effective in against the gut bacteria, is sometimes effective in this irritable bowel syndrome patient. Rarely, this patient may present with symptoms of subacute intestinal obstruction without any specific cause. They may be having some chemical food intolerance, but there is no definite association proven. Mild intolerant to lactose, fructose, sorbitol, but what we have seen that whenever this patient present, we sometimes as a physician, we blindly tell them to stop milk, stop roti, or stop gluten containing diet, which is actually not an ideal management. It is the patient who needs to understand which food is causing me the problem, and according to change the dietary habit. Sometimes, yes, the patients have lactose intolerance. Sometimes they have gluten insensitivity. Despite that, you will not find an obvious either histological or chemical or another diagnostic feature of gluten sensitivity or celiac disease. Rarely, patients are intolerant to salicylate and benzoate present in certain food. Now, as we see, there are various subtypes. Sometimes it is predominant constipation. Sometimes it is predominantly diarrhea. Of course, the reason for constipation is the decreased orocecal transit time, reduced number of high amplitude propagated colonic contraction waves. So irritable bowel syndrome is just about defect in intestinal motility. But you will not find any consistent evidence of abnormal motility. So actually, all kind of diagnostic tests are done that is actually to exclude other disease. No test is specific for irritable bowel syndrome. It is diagnosed based in symptoms. Then another subtype of irritable bowel syndrome is IBS-D, or irritable bowel syndrome with predominantly diarrhea. So one is decreased motility. Here you will see the jejunal contraction increases. That is why intestinal transit increases, and that is why it causes diarrhea. Again, colonic contraction will also increase.